like this before, and if you've got any questions or anything, just jump in.
Okay. So I'm going to record the session. I'm just starting the recording.
Okay. And
Okay.
I'll start the introduction. Hi and welcome to all of us. And before we begin, just check that your mic is muted during the meeting and that if you have your phone with you, see that it's on silent, please. Thank you. Hi, Nicole.
Hey, putting my phone on silent.
As a self-introduction, I had asked her and she tells me she enjoys food, wine, good company, the beach, art, interior design, flowers, reading, and of course, travel. And now with the much curtailed travel embargoes or restrictions, as whatever term we can use, at the moment, she's on the journey, loving her own country and camps in a caravan on the weekends. Nicole, an expat wife and mother, lived in KL, Penang, and Bahrain. And we met Nicole through our book, for the love of our books, through our book club. On returning home to the Gold Coast, she worked as a tour guide commentator for the Aqueduct. It's an amphibious city tour, and at the Palazzo Versace in reservations. Nicole had a 360-degree rotation on her work choice, entered the health field, and in two fabulous words, Nicole describes the experience in OT, loving it. It's over to you, Nicole.
All right, thank you very much. Thank you for that. Thank you everyone for giving up your Saturday morning for you, yes, to tune into this, and I hope that you enjoy it and maybe learn something, maybe not. Or as I said before, please feel free to ask any questions or punch in with any comments that you might have from your own experiences. I will start off and say that I'm not an occupational therapist, I'm an occupational therapy assistant. So a lot of my information is really, again, through my own experiences and not through study so much, more the experiences I've had over the last 6 or 7 years that I've been in the field. So essentially, I started this job, as Sharon said, following on from, I've been in hospitality. We'd come back after being expats. And my dad had actually had a stroke about 20 years ago. And he, at the time we were living in Malaysia when he had the stroke, and we sort of flew home to be with him. He had his stroke, it's a little interesting side note, at Mount Everest. He was not actually climbing the mountain, but he was at base camp. He was part of a group of his friends that decided they wanted to do the overland tour, which they'd done when they were very, very young. And so they went to do it again. And for whatever reason, he had a stroke. No one knows. He wasn't actually in any risk categories or anything like that. But sometimes in life, things just happen that you can't control. He had a very interesting, I think it was 24-hour journey in a Jeep to get off the mountain and down to the nearest hospital, which was basically a mud brick hut. And then he was actually medevaced from there to Hong Kong. And then they flew my mum and her sister out from Australia to meet them in Hong Kong and flew them all home again. So one thing I will say, aside from everything else, is travel insurance is very, very important, because without that, my parents probably could have actually been bankrupted, because it was something like I can't remember at the time, it was something like a $2 or $3 million bill for that particular extraction to get them out of there. So I never go anywhere without travel insurance again. That was my lesson I learned from that. Anyway, so he came back to here. He'd been acute in the hospital in Hong Kong, and I can't think of the village in Nepal it was called, but anyway, he came back, he entered rehab, and he basically spent, I think, 6 months in rehab here, which was actually quite a long time at the time. We don't have the same length of stays anymore so much. It really just depends on how the patient's progressing. But he was lucky enough to be admitted to a public hospital that had a really, really good rehab centre and really excellent allied health team. And at the time, I remember he was doing all his exercises. My dad's very dogged. If you tell him to do something, he will do it. But when they actually came back, they were kind of telling us to prepare for the fact that he would never sort of walk or talk again, that we might need to start modifying the house. And as it stands, he was discharged walking, he drives. As he ages, things are getting a lot harder for him, but he's had a really, really good recovery, except he never got anything back at all in his right arm. So his right arm's in a contracture, he holds it like that. He doesn't hold it, it goes like that irrespective, he can't control it. But that was kind of the first touch that I ever had into the health arena. I'd never really thought about it before. And it was my first experience, and I was impressed by the therapists. I just thought that they were clearly making this big difference to my dad. You know, it was the difference between him wanting to live and probably wanting to curl up into a ball and die, because he was at the time quite young. He must have been in his mid to late 50s. not prepared for that kind of life, you know, that early on. We all know we're going to get older, but he didn't think it was coming quite so soon for him. So when I came back and I looked at things and I wasn't really happy in the job that I was doing, I just wanted to be a bit more a part of our community. Being an expat, it's hard to feel a part of community because you move so often. I had that opportunity. Probably Bahrain was only the second time I've ever had it because we've been there for 7 years. So it was nice to be able to go to book groups and do all those things and just know the local shop, the girls in the shops, and just give them away because I've sort of seen them. So I wanted to do something that sort of made me more of a community here, and that's why I chose health. Also, a friend of mine was just saying to me that I should have gone into diversional therapy because I can talk a lot. I can sort of talk to anyone, and I've usually got, I would like to have been a cruise director, maybe in a past life. I've got that kind of personality on any given day, on a good day. However, there wasn't any courses in that. So I looked around and looked at occupational therapy, and I just thought it was really interesting. I'd never really heard of it before, to be honest. Physiotherapy was the thing that I'd heard of, which is what everyone's heard of. But occupational therapy was a bit broader, I thought. So I did a 9-month, what we call a TAFE course here. I don't know what you'd call it in other places, but it's a certificate. It's I think it's not a diploma, it's one below a diploma, I think. Anyway, 9 months of online study, and then I had to do 4 weeks of prac. And a lot of people say to me now, why did I not do a degree in occupational therapy? And it basically boiled down to a simple matter of numbers, return on investment for the age that I was, the fact that I would have to study part-time for 8 years to also work full-time to pay bills and live a life. And by that time, I'd be in my early 50s. With a large debt from university and really not the working life to be able to pay that back and enjoy the job, but also sort of progress a career. So that's the reason I chose being an assistant, because we kind of have, I say all care, no responsibility, and I don't mean it that way, but we get told what to do in the nicest way. We work with fantastic people, and yet I don't have the responsibility for leading that patient's rehab journey, but I can be a really important part of it. And sometimes when we have new staff, we do actually lead them. Even as assistants, we say, oh, look, we've seen this work before. Do you want to try that with the patient? So we play a really important role, and we always do call ourselves just assistants, but it's a really interesting role. And I think that it's an interesting way that the service or the health service enables a lot of allied health teams to have a lot more patient contact without, obviously it's budget driven, a lot of things, without paying for those large salaries that obviously health professionals get, and rightly so. They have a lot of study behind them and they have a lot of knowledge. But by having these assistants, which we're trained well enough in what we do, they can actually, we can see patients 2 or 3 times a day, whereas if they only had health HPs or health professionals, they might be seen once a day. So it really does give intensity of therapy to our patients, and that's, you know, as part of being an assistant is actually supporting that team, but just leading to that intensity. And we also put our hands up to do other things like handovers or things that the staff get really stuck on if we're short, if people call in sick. So it's a very multifaceted role. It's almost, I call it a little bit like being a Girl Friday. I don't know if that term means anything to anyone, but you sort of a jack of all trades, master of none, and you just help out and scoop up whatever you can when required to help out the health professionals. So that's my story. The definition of OT. Now, there's 1,001 definitions. I like this one, which means activities of everyday life, named, organised and given value and meaning by individuals and a culture. Occupation is everything people do to enjoy themselves, including looking after themselves, enjoying life and contributing to the social and economic fabric of their communities. And there's another adjunct to that, which is saying that basically chunks of culturally and personally meaningful activities in which people engage. So it's even, you know, such as you ladies all tuning in today, if you didn't have the ability to turn on your computer or didn't have the ability to put on your headset because you had a hand or an arm injury, you wouldn't be able to meaningfully engage in something that gives you pleasure or gives you joy. And it doesn't have to be, an occupation doesn't have to be a job. I think that's the greatest misconception about occupational therapy. They think, oh, you're the one that's going to get me back to work. And it's like, well, potentially, yes, we are. We hope to get you back to work, but we're also going to get you back to doing those everyday things that you might not think is an occupation, but they actually are. So maybe it is reading a book, and maybe you can't open that book anymore, but we need to figure out a way that we can get some kind of adaptive device to keep it open so that you can read the book. Maybe you've got a visual impairment and your brain won't allow you to see all the way to the end of the page. We might put a line of red tape along the end of the page so you can actually read to it. So all these little prompts and cues are things that enable you to enjoy what you do as an activity of daily life. So there's basically, it's broken down into PADLs and ADLs. And ADLs are activities of daily life, and that can be literally anything from pulling on a t-shirt, to driving a car, to going to work, to reading a book, to going for a swim. It's an activity that you might do in your daily life. We also have PADLs, which are your personal activities of daily life. And these are the ones that we all do. So it's brushing your teeth, showering, going to the toilet, probably a little bit personal, but wiping your bottom, all those things that we just do straight away without even thinking about it, but can become really, really difficult for people when they've got different kinds of injuries and limitations. So, where I work, just a little tiny bit of a background about where I am. I'm in a major hospital, which is about 10 minutes down the road. We've got 750 beds, and I work in a 30-bed rehabilitation unit. When I say rehab to people, people always think I work in drugs and alcohol rehab. So there are other kinds of rehab, even though I do enjoy a glass of wine every now and again. Basically, we get all of the brain injuries, the traumatic brain injuries from accidents. We get the acquired brain injuries, so TBIs and ABIs, from people that have perhaps had a stroke while they've had surgery, or they've had a stroke. They might have a congenital nervous condition. They might have heart conditions, or they might have been in ICU for 2 or 3 months, and they're so severely deconditioned that they can't actually even get out of bed. They can't stand up because they've been laying in a bed for 3 months. So we get lots of different patients, from quite mild. Some patients might stay with us 3 or 4 days, to quite severe. We recently had a young fellow who had a scooter accident, so a little kiddie scooter, not the electric kind, but he was 16 at the time, I think. Didn't have a helmet and just fell off his scooter, and he unfortunately hit the curb just the wrong way. So thousands of kids fall off their scooters every day and have nothing happen to them. This poor fellow had a brain injury. He was in intensive care for I think 6 months, and he came to us for about, I want to say 7 or 8, I can't remember exactly, but he had to learn to walk, talk, eat, breathe. He had to learn to do everything again. And he walked out. He does have a brain injury. His personality is a little bit different, and he's a little bit slower. His processing time's quite slow, and he will probably have more problems. The unfortunate thing with any kind of issue that you have, even if you're young when you have it,
Is she frozen, or is it only me?
I think she's frozen.
Yeah, she's frozen, I think.
Yeah, I can't hear her either.
No, but she's not there. Yeah.
Oh, she's hi Nicole. Hi Nicole, we missed you for about half a minute.
Sorry, I don't know what happened there. I'm like, oh, I was scared. I was telling you about a young fellow that was with us. So just basically saying that any issues that you have, can come back later in life. So he is currently living a fabulous life. I see him occasionally in the shops. He's got a little job. It's not to say he's always a changed person. He will never be the person that he was. And that's one of the really important things that I tell all of my patients, the ones that have got the mild things, the ones that have got the major things. They just have to find a new normal. So we all have a normal, we all have a way that we do things, and we just have to find a new normal. And that's harder for some, easier for others. And unfortunate that some people have to do that, but that is life, unfortunately, and things are unfair. And I quite often, it's very difficult working with patients that obviously feel, that they're in this situation and it's not fair. And I agree, and there's nothing you can do except agree with them. And, I always say to them, I wish I had a magic wand for you, but I don't. However, we will do everything we can to try and make you feel better and try and get you back to yourself as you were, but with a different slant. So finding that sort of new normal. Does anyone have any experience of anyone, family or friends, being in rehab or having that sort of protracted healing period for a big injury? Yeah? Sheree? Sorry, I didn't say.
Yeah,
do I have to push? Oh.
I myself, I had meningitis in 99. And yeah, I had low limb immobility, so I was on a wheelchair. And yes, so it was
I
really,
didn't know that.
And yeah, so it was basically getting back to walking.
Yeah,
And
okay.
yeah, so there has been, yeah, so I have had the physiotherapy. Yeah, so that I have had a sort of, yeah, I have been in rehab.
Yeah, okay. How long was your recovery?
Recovery for movement, mobility was, I think, 6 weeks.
Okay.
And yeah, and then of course it was a catheter. I had a catheter on, and yeah, so
Yeah.
but again, that kind of resolved because I was moving around with the catheter.
Yeah, okay, wow. Yeah, and I don't think until you've had that experience that you kind of realize how much we take for granted,
I
you know,
know.
how much we assume that these things will always be easy.
Yeah.
For me, it was my ankle last year. I've never had surgery, I've never broken anything, and all of a sudden, to get on and off the toilet I couldn't do it. Like I'm not strong, I'm not particularly fit, and because I couldn't weight bear on that ankle, just getting up and down off the loo took me forever. And I think not need, but I think it's valuable in life to remember that lived experience is sometimes one of the things that really makes you appreciate what other people are going through. So as part of the allied health team, in hospital, you'll get usually an occupational therapist, a physiotherapist, a speech pathologist, social worker, psychiatrist, and a dietitian. So there's usually about 6 or 7, or plus all the doctors, obviously, and then you've obviously got nursing support. So there's a big team. It's called an allied health MDT, multidisciplinary team that look after you. Some patients might not have all, some will have some. So for example, a stroke patient will usually have speech pathology, physio, occupational therapy, social work, not usually dietitian unless they've got diet issues. Whereas we do get some stroke patients, and we've got one at the moment, for example, that has everything's perfect physically, but they've unfortunately got severe dysphagia, and we can't understand aphasia and dysphagia. So what's going in and what's coming out, we can't understand what's coming out, and they can't understand what's going in for them. So it really depends on how your condition is as to what part of the team that you have. And one of the funniest things about OT, and it was probably the first thing that I learned when I started working there, because I only knew physiotherapy as well, is that most patients, they come to the gym, we have a daily schedule for our patients, and they literally will have 9 o'clock physio, 10 o'clock OT, 11 o'clock speech, lunchtime, 1 o'clock social work, 2 o'clock. They have a full schedule, and you'll get the patients that never want to come to OT. They're like, I just want to walk again. That's all I want to do. So they've maybe had an accident, and they've got maybe a broken shoulder. They might have a broken leg. Maybe they've got a brain injury. They hit their head as well. There's never one thing that comes out of these. These patients usually have multiple issues. And like, I just want to walk. I just want to walk. I don't want to go to OT. And the basic thing that we end up saying to them, and it takes sometimes that hard reality, we say to them, okay, great, you're going to walk. So you can walk to the toilet, and once you get there, how are you going to wipe your bottom? And I know it sounds crude, but that's what it takes for a lot of people to sort of understand that, yes, physio is important, 100% it's important, but everything's important. And yeah, you're not going to feel independent and strong if you get to the toilet, but then you have to call for someone to help you wipe your bottom. So basically, that's why we work as a team, to basically look at the patient as a whole and to see, how we can best help them. And the allied health, I don't know much about medicine. I've only ever worked in rehab and in this allied health team, but they're a fantastic team. They work so collaboratively. We have meetings every morning. There's case conferences. There's all these things that are all focused on that patient, and everyone says their bit and everyone nuts it out, and we plan joint sessions. And we basically might say, look, we're going to back off on the OT while you get their walking going, because that is their priority. And then the PT will back off a little bit and not book so much in, so that we can book our stuff in. So it really is a team effort. And I say that to patients. And again, we're lucky in Australia. I know it's not always the same in every country, but, particularly in this hospital, in this country, there's an army of people that are looking after you. So I say to the patients, I know sometimes it's frustrating, it doesn't feel like anything's happening. I said, but behind the scenes, there's an army that are looking out for you, and all they're thinking about is you and how they can make you better and what we can do to actually fix what's wrong with you. Not fix it, but try and find ways for you to work around it. So in my job, I'm going to do one little thing first. So in my job, I do probably 70% clinical work, maybe 30% operational. And operational can be anything from cleaning equipment, ordering equipment, going and bringing the car around for a home visit, going down to the kitchen to grab food if the patient wants to cook, all sorts of random things, laminating signs. It's kind of a true I can't even think of all the things, but any given day is quite random. But we also do clinical work, and we're very lucky as assistants that some assessments we're actually allowed to conduct. So we get training, we have basically they're called in-services, and then we have competencies we have to be signed off on. So we do our certificate, we get our qualification for that. And then once we start work, we have, this is in the public system, it's probably not the same in the private, but I only know public. But we basically, hello, we essentially, we do our competencies and we get them signed off by one of our health practitioners. So usually for me, it's my OT, and I have to have a senior OT. So she will give me the work stuff to study. I will look at it. She'll give me a few little quiz questions on it. She will then observe me working on a patient with it or doing that particular assessment with the patient. And if she's happy, she will sign me off. If not happy, she'll ask to see me do it again, or she'll coach me through what I need to be better at to be able to do that assessment proficiently. And then we are allowed to do some assessments. So as a little test of that, I'm going to give you all a test. There's an assessment that we do that some of you may not be familiar with. It's called a MOCA, which I think is a Montreal something assessment. I've actually forgotten, but it's called a MOCA. And beware, everyone, when you get older and they're trying to say to you it's time for the old ladies' home, you need to know these words. So the words that you need to remember are, and I can never remember them myself, I'll be the first one that goes to the old ladies' home: face, velvet, church, daisy, and red. And we only ever say them twice to a patient, and then they're allowed to write them down. It's face, velvet, church, daisy, and red. I'm going to ask you to remember them later on, see how you go. But that's one of the things that we do. We do those kind of assessments with, we don't usually do physical assessments, but we do cognition assessments. And so we'll basically, some of them are half an hour long, some of them are an hour. We have to document those into IEMR. And I personally take them very seriously, because sometimes that is, it's not the pivotal thing, but it's certainly one of the major things that the treating team will look at when they're looking at a patient. Maybe they're querying their cognition, they're not sure if they've got dementia, or they're not sure if they've got delirium, and they will look at these assessments. They'll look at the notes that we make, they look at the end score, and a lot of the times the treating team will use that as a pivot on what they're actually going to do with that patient. So it's a big responsibility, and as assistants we take it really, I mean, everyone takes it seriously, but it's a privilege for us to be able to do them, and we take it very seriously, and we do have to do those. So one of the things we do is assessments. I haven't got my glasses, that's why my paper's up high. And a lot of the other clinical stuff we do is we'll do, for example, a group therapy of 8 patients. And so we'll have an OT that helps us with that. But essentially we'll have 8 different patients at a table doing any number of activities. It could be upper limb retraining, it could be memory issues, it could be cognition with bill pain and things like that. So we'll have a group of 8 people, or they send us out to do one-to-ones. And basically it depends on the level of the patient. We call a patient heavy. If we say we've got a heavy patient, it doesn't mean that they weigh a lot. It means that they require a lot to get that therapy done. So they can be heavy in the sense that they might weigh 50 kilos, but they cannot stand. They cannot use a Serosteti. If anyone doesn't know what a Serosteti is, it's kind of like an implement that we wheel up to the bed. It's got foot plates on it. The patient holds onto a bar. They lift themselves. We put a seat behind them. We move them to the wheelchair. We do the whole thing reverse and pop them in. So that would be a heavy patient, because it takes a lot. It takes 2 people to do that, to get them going. And if I had a patient that had a severe TBI or a severe traumatic brain injury, he would be a heavy patient, because I can't put him in a group. There's too much distraction. He requires a solid hour of one-to-one, quiet area, no distractions, everything very clear, concise and slow. So we have what we call heavy and light patients. And the light ones are the ones that, again, they might weigh a lot, but they don't require a lot of, they need input and they need therapy, but they need it less intensively. And we can do that in groups for them, or we can do different things. We can take them out. We can sort of do a lot of different things with them. So some of the other stuff we do is I might be in any given day, and each day is different. It depends on what kind of cohort we have coming through of patients. But I can be showering with the patients, not with the patient, that sounded really bad. I can be helping a patient to have a shower. We might be testing to see if they can use their affected limb, if they've had a stroke. If it's cognition, I might be watching them to see if they can actually sequence all the steps. Sequencing is a big thing that we do, which a lot of people lose when there's cognitive issues. So it's simple things like making a cup of tea or coffee, which again, you would do without thinking. But people have had a brain injury or a stroke, or perhaps they've got a bit of dementia, they actually struggle to do that. And that's a good example of an activity that has a long step process, in the sense that we will talk about it, and we might even just do for an hour. We've got picture cards that have all the steps of making a cup of coffee. So one shows someone switching on a kettle, the next picture shows someone putting some coffee into a cup. There's probably about 10 of them, and then they have to put them in order. And as they get them wrong, we let them do it wrong, and then we correct them and we talk about it. And then maybe the next session we'll actually go into the kitchen and we'll actually make the cup of coffee. So we've got all the items the same, it's the same kettle we've photographed. We try and keep it as continuous as possible. Not always possible, but we do try our best. And then those patients might literally, for 2 weeks, go and make a coffee every day with us. And literally that's because they're getting it so wrong to start with. I've had patients put the kettle in the fridge, they've put the coffee into the kettle, all manner of things, which in retrospect is quite funny. And we don't laugh at our patients, we have a laugh with them. We do have a chat in the staff room about some of our funnier ones sometimes, but we work with them. And, if it's possible for that patient, and with that time, we can get them to be making a cup of coffee. And that them making a cup of coffee might be the difference, not always, but it might be the difference between them being able to stay at home or go to full-time care, because they may live with their daughter or son who needs to go out for work 3 or 4 hours a day, and they say, well, I need to make a cup of coffee and I can't go home. If you can't go home, if you can't do that yourself, if you can do that yourself, you've got someone that'll be there to help you make the breakfast and the dinner, and they can leave you a lunch. And if you can make a cup of coffee, so it's quite often very, very small things. And that's what I've learned about watching my bosses and the team that I work with. Discharge planning is a big part of what OTs do, and they plan. Obviously, the patient has to be safe, and they have to be, if they're living on their own, or they'll be at home on their own for part of their day, they have to be able to manage. And so I've sort of seen how small things can actually prevent someone from going home. So someone, for example, that can't transfer safely, if they don't have the cognition, or they don't have the strength and ability to safely get their four-wheelie walker to the toilet and pop themselves on the toilet, they can't go home, because their daughter that they live with may work 6 or 7 hours a day. So it's those kind of things that we work on. And quite often patients, they do get not bad-tempered, but like, oh, this is ridiculous. Oh, I'm doing this for, I can do this. She has to go to the toilet. I'm like, yeah, but you want to be on your own for a certain amount of the day, and you need to be able to do that. And it's only when patients really faced with that, we need to fix this, or you can't go home, that sometimes it gets through to them that they really do need to work on this. And you've got extra problems when people have physical mobility problems as well as cognitive. It's a big challenge to try and get them to that stage that they can actually understand that and complete it. I've got a lovely lady at the moment who actually doesn't have any cognitive deficits, but she has a brain tumour, and she isn't able to use the left side of her body correctly. It's very weak, and she has a lot of motor planning control, so she can't sort of control this hand so much. And we're trying to get her at the moment to transfer, because she has a husband at home that can help her, but he does go out, so she needs to be able to transfer to the toilet. And bless her cotton socks, we've been doing it for a week and we're not there yet. She literally can't retain the information that we're giving her about safe foot placement, making sure she's in the right position. And every time I practice with her, and it's been daily for the last 2 weeks, she would have fallen if I'm not there. So I'm there for the steadying assistance, and I keep reminding her, and we're just, oh, yep, she does it all great. And then the next day I go and it's gone. It's just gone. And that's just, unfortunately, she's got a really crummy memory. Perhaps it's the start of something, perhaps it's not, but she's also quite rushed, I think, and she's always in a rush, and she just forgets to do what she needs to do. But that will stop her from going home, and she can't stay in hospital forever. There are hospitals, we never release anyone, we never kick people out, to put it that way, but we have KPIs, we have budgets, and we have certain length of stays that patients are allowed. And at a certain point, we can't push it out anymore. And if she can't go home, then she will have to go to a nursing home. And this is a young lady, or not young, well, she is young, she's in her 40s. She doesn't want to go to a nursing home. So she needs to be able to get that right before she can actually go home. So some of the other stuff we do is wayfinding. So I might in my day walk a patient downstairs and say, right, I want you to show me the way back to the ward. We go and get a coffee at the food court downstairs. I love those kind of jobs because it's kind of like a little 10-minute break for me too. Even though I'm working and I'm with that patient and I have to be aware of what they're doing, that's sort of the variety of spice that adds to our day that I really like. The physio assistants are stuck in the gym all day. I get to go all sorts of different places. So that's one of the reasons I like occupational therapy better. It's a little bit broader in that sense. We might be doing feeding with patients. So we touch a little bit on speech components. We don't do a lot of speech learning, which I would like to do. And I'm currently in the process of trying to find out if we can do. We'd have to change some of the course requirements, but I would like to try and add in speech because it's really important when someone, mostly for speech or for brain injuries, but if they've got poor swallowing, people can choke to death. And I don't think people realise how easily that can happen. If you've had a stroke and you can't swallow properly, you will inhale fluid and you'll get water on the lungs, and it's a slippery slope from there. And we have family that constantly come in and say, oh, but it's his favourite drink, this, he really likes it, it'll cheer him up. And it's like, yeah, but it might actually kill them at the same time. So that's an education as well. And I didn't know until I'd started working there that you have to have thickened fluids, and they're not nice. I'm going to be honest with you. It's kind of like drinking not really set jelly. Can you imagine having a coffee that's like jelly? It's not nice. But if the person really wants that coffee, then that's the way they're going to have it. I usually say to patients, if you can hold off until you get better, and if you can strengthen those muscles, wait for the real coffee because it'll taste so much better by the time you have it. But we touch a little bit on speech with that. You quite often see patients that have tape on their faces, and that's to retrain their muscles. If you have a stroke and your face droops, they'll actually have sellotape. Oh, well, not sellotape, it's medical tape, but it looks like sellotape. They look like they're a sort of badly patched jar. They'll have it here, they'll have it there. It's kind of like the facelift you never knew you wanted. That's what I always tell them when I say, I said, your other side are looking as good as that side any day now. So we do a little bit of things like that with a speech therapist, not a lot, a little bit. Occupational engagement, there are patients that are not, we probably can't really do any more for them therapy-wise. They may be waiting for nursing home placement, but they haven't got anywhere yet, or their family is maybe waiting for home modification before they can take them home. But we will take them out to, we've got a garden there, we do a bit of gardening. And again, it's about those activities of daily life. That's something that they enjoyed. We don't take someone gardening if they didn't like it. We find out what they like. And we might take them out gardening, or we've got a barbecue, so we try and get the guys that enjoy that kind of thing. If they're cognitively intact and they're not going to hurt themselves, we'll go out and do a barbecue with them, or sort of things like that. So there are patients that we're not doing therapy so much with, but occupational engagement is a big part of what we do because it's keeping people engaged. We've got people that have been there for maybe 3 or 4 months, and, you know, that's a long time to be in one room and one ward. And if they haven't got family to take them out, they're there for a long time. So we kind of play a little bit of a, I suppose it's like an assistant and nursing role in that respect, and that we try and sort of give them a little bit of time, engagement time, and also it's just treating them as a person and not just a patient. And that's the beauty of our role. We do wear a uniform. We don't, so they know that we are not nursing staff, but we're part of the team. But they know that we are not, you know, not pharmacy. We're giving them medical instructions. They know that we're there just to make them feel a bit more like a human being. You do feel very much like a patient, obviously, when you're in hospital, you are a patient. But I actually met one of my past patients about 2 weeks ago at the local bowls club. She had severe aphasia, and she actually left with severe aphasia. We can't understand what she's saying. She has, her receptive is good, she can understand, but what comes out is just, it's not understandable. And she'd been left a year, and I saw her having a great time. She's got a supportive partner. She was having a lovely time listening to music, and I actually said hello to her, and she was able to say hello to me, and also in broken down words explained to her partner that she knew me from the hospital. And for her, that's amazing. We were not able to understand anything she was saying. So that's the joy in what I do, and that I get to see patients become people again. And like I said to her, I said, it's so lovely to see you in person mode. I said, with your clothes and your partner and out in the community doing what we all do every day. So that sort of thing is what OC engagement is as well, just treating them like as people so they're not patients all the time. We might put a patient on a computer and plan a transport route and ask them to plan to go from A to B, and how are they going to do this, and who are they going to call if they have a problem. That's a lot of the cog retraining that we do. We do a lot of upper limb retraining. So when you have a stroke, or if you've had a brain injury, more often than not, one side of your body's affected. And then we have what we call our dense arms. If you've got a dense arm, it's not going anywhere. It's not moving. You can't move it. You have dense legs as well, but we obviously the physios deal with that. We deal with the arm. And we do a lot of upper limb retraining. So that usually starts with things like Easton, which I don't know if anyone's ever had a TENS machine, but it's a little bit similar to that. So we put the pads on, it gives it electric shock, and then it gets that. We start with usually wrist flexion, depending on what's wrong with the patient. But, you know, and again, as an assistant, I don't have all that knowledge because I don't have that degree, but the OT will say, right, this is the weakest muscle, we're going to start on this. So I'll hook them up and then I'll spend that hour with them, encouraging them, counting their reps. A lot of what we do too, we do a lot of coaching courses as part of our in-services and our teachings that we do in hospital. So we do coaching courses. It's highly underrated how important that is when you've got a patient that's, you know, struggling to do that, and we learn coaching skills and simple things. And it's a terrible one for me to, easy one for me to remember, but hard to do because I talk a lot. Like, no, not so much talking. If you want someone to do something, you simplify it, you ask them, you give a little bit of encouragement, but they are focusing. It's taking all of their energy to lift that wrist up. They don't need any outside noise. And by doing things, we do some passive ranging where passively we actually move it for the patient. There's not much evidence for it, but sometimes we do it just to give patients that human touch. And if they've got an aching wrist or something, we sometimes massage it, just a light rub for them at the same time. But it basically gives them that movement, makes them see that they can do it. And we also have things like mirror boxes. So if we've got them on Easton, we'll put a mirror box in front of them so they can see that actual hand going up, or we might even put their good hand doing the action and the mirror box on the other, trying to encourage the affected hand to come up as well. We do things like edema massage for patients. So if you've got a limb that's not moving, you can, and quite often, more often than not do, get a lot of fluid retention there, and that can be very painful. And not only is it painful, but it limits movement. So if we're asking someone that's got a very swollen hand to move their wrist, I'm sure if any of you know, if you've ever had, you know, a sprained wrist or something where you've got a lot of fluid around the joint, it makes moving it quite difficult. So we do a lot of edema massage as well. And we've done a lot of recently burn spot massage. So we have patients come in that have had severe car accidents. You know, one young fellow recently had a brain injury. He had burns to, I think, 50% of his body, and they were deep. They were full thickness burns. He had grafts all over his body. And to be honest with you, the parts that weren't burnt, they'd had to harvest skin from the good parts. So practically all of his body needed massage and looking after each day. So we would do that for an hour a day, and he was with us for probably 4 months. So we'd do it in teams of 2. It would take us half an hour, or one person, it would take an hour. And you can imagine if you're doing that for a patient, the rapport that you can build up with them, that's the perfect time. You know, we're treating them and we're doing something that they need, but we're building rapport with them at the same time. And again, trying to find out about them as a person so that we can actually direct their future therapies into things that we think they actually want to do to achieve what their end goal is. We're very goal driven. I think most health things and a lot of things in life these days are goal driven. So, you know, we don't do that. Those therapists do that with the patient. They sit down and they make SMART goals with them to really make sure that we've got target points along the way so we can see what they're actually doing and why they're doing it. And a good example of that is we've just had another upper limb course at work, but we do pre-shaping for picking up a cup. So, you know, for a lot of patients that have had that dense limb and they haven't been able to move it, we might get a patient to literally just put a straw. We'll put a straw on a little marker and we'll say, bring your thumb up, tap that straw, And they're like, what the hell am I doing this for? This is a waste of time. Like, I don't want to do this. But we're like, yeah, but when you want to reach for that cup, that thumb's going to have to come out to do it. It's going to abduct and you're going to shape that whole hand. Then the next part of the exercise might be just moving the fingers up. So it depends on what the deficiencies the patient has in their hand as to how they're structuring the exercises, but it's a lot of part practice. So we practice this, we'll practice this, and we'll actually put something slidey under their arm if it's very dense and they're finding it difficult to do that shoulder movement. We'll put what's called BedX or even slide sheet under their arm so they can actually get a little bit of assistance but still do it themselves. So that movement and then a bicep curl and then this and this is all building up to just reaching for a cup. And it might take the patient 3 weeks to get to the cup point. But when they get there, it's like a light bulb moment. They're like, of course, that's why I was doing all these individual things, because it leads to one movement. So it's a lot of part practice and it's a lot of not tedious work for us. I mean, we love it, but for the patients, sometimes it's hard to keep them motivated. So we kind of have to always, you know, put that goal in their mind. We've got a fellow at the moment who's got a mild cognitive impairment, quite mild, but he loves his beer. And we've basically printed out the logo of his beer and put it on one of our therapy cups. And we're like, that's the one you're aiming for, buddy, because that's what he wants when he get out. Probably too much of it is what put him in the first place. We don't know, but that's not our place to judge. And, you know, everyone's got their own story, but that on there made such a difference. He was actually engaged. He was reaching for it. He was, and I think he thought it was funny, but also it just gave him that kickstart into like, this is what I'm doing this for. This is why I'm doing this activity, because I want to be able to bring a beer to my mouth and I don't want someone to have to do it for me. So simple things like that make our park practice into a whole. We also do upper conditioning, so basically reps. You know, we might do biceps, shoulders with weights like you would in a gym. A lot of our patients have been in ICU, intensive care unit, or they've just been really unwell for a really long time. And there is a stat that I couldn't find, I was trying to find it before, that basically says that even if you're an athlete, if you lay down or lay in a bed for like 2 days, you start to decondition. Deconditioning is a big term in our rehab. And yeah, even the fittest person will start to lose their muscle tone, their strength, their coordination if they're in bed for that long. So you imagine if you've been in an ICU for 6 months, you're starting from baseline 0. So we have little tiny like 0.5 weights right up to the 5-10 kilo ones, just depends on what the patients are doing. We have masses of equipment as part of OT. That's one of the banes of my existence, is keeping track of it, because the OT therapists, I feel like saying to them, you've all got degrees, could you put things back where you find them? But they never do. They put them everywhere. So it's one of my jobs to run around and find everything and keep it all clean and tidy. So that's kind of one of the operational, not clinical aspects of the job. We're very lucky where we are that we have what's called a life space area, and it's essentially a little pretendy supermarket. We've got a cash register. We've got all empty boxes of things that we fill with rice to make them have weights. It feels like you've actually got a packet of Omo or a juice box or whatever it is. And we have a little smart car up on our wall. We're on the 5th floor of the hospital, but they craned it up when they first built the hospital. So we can do things like taking patients shopping, you know, and as much as they think, oh, it's a bit silly, it's amazing, again, because they're all physiotherapy focused. I want to walk, I want to walk. I want to be, but like, yeah, okay, it's great that you can walk, but if your standing balance is great when you're, so if a physio says to someone, I want you to stand up and sit down 100 times, sit to stands, and that's what they'll do. And then they'll say, I want you to reach out, you know, to this cone and touch this cone 100 times. They think it's more valuable than what we do in life space. But as we try and say to them, it's all about putting all of that together. It's great that you can sit to stand 100 times, but what if you had the distraction of watching TV at the same time, or maybe your cat came around the corner and rubbed up against your legs? Or so what we do is put all those exercises into context in the real world. And so for a patient, I had a patient the other day that's broken a hip, and she's just up, she's very painful for her, an elderly lady, and she's been doing all her sit stands, and she's like, oh no, I'm fine, I can stand up. But the activity was for her to stand and make some toast and tea, because she lives on her own. And yeah, halfway through, she's like, oh, because she was so distracted by the tea and the toast and hand here and checking that and that she wasn't really standing well. She wasn't taking rest breaks. And she actually acknowledged, because she didn't want to do it. She was a real cranky lady. She's lovely, but she was just cranky. And she said, I can understand, because it's one thing to stand, but it's another to do other things while you're doing it. And so it's putting it into that real world context. I think if we didn't have OTs and didn't have these systems, we would put people back that are in some ways physically fit in the community, but they're not actually coping because they're not able to put everything together. They're not living in a gym doing this, that 100 times. They're living in a home that's got trip hazards, it's got carpets, they've got to navigate sofas, they've got to navigate animals, all these things. So our life space area we use a lot. We've got a little library, we've got a kitchen, we do a lot of cooking with patients. We've got our car, we've got our shopping area, so we take them on all these activities, and we use the outside community. We've got a tram right outside the hospital. We actually use that. We've actually taken patients, and I love that too. I get to take them on the tram, we go down to the water, we have a look, one stop, and then we come back to the hospital. And that's work. I love doing that. I mean, it is work, and I am there to work, but I love doing things like that because it gets me out in the community as well. I think that pretty much covers, I mean, we do things like desensitization for patients that have nerve issues. A lot of stuff we do is upper and lower limb dressing. So we actually retrain patients how to dress. If you've got one hand, it's quite hard to do things. And a lot of patients, like my dad, will never regain the use of that hand or that arm. So they need to be shown a different way to do things. And it can be done. It's not that difficult, but they just need to be shown and to practice it in a really supportive environment. And that's what we are. And I know that a lot of patients, I can see it when they get close to discharge, you can see they get quite sort of not nervous, but they just get a bit cranky and a bit unsettled, even the young ones. And I always say to them, how are you feeling about it? And I'm like, oh, yeah, that's all right. But I said, you guys are all so nice here. You're so protective and you're so nice. And I'm like, yeah, we are. I said, but you just need to take your time out there, and random strangers can be supportive too. They also cannot be. I said, but you need to do your thing, and it's a very important thing, particularly for stroke sufferers when they're walking. If walking's difficult for them, like my dad, bless him, if I see him down at the road at the shops, he doesn't walk very much anymore. He's got a bit older and hasn't been as sure on his feet. But if I do see him, he uses a stick and he will not acknowledge me until he finds a seat to sit down, and then he'll turn around and wave at me. He can't look at me and focus on walking at the same time. That's too many things for his brain to do. And he knows it. So he does one thing. He picks one thing, then he'll sit down and people think he's rude, but he's not. He just can't do the two things at once. So I think, it's important. I mean, we all are people that have empathy and understanding. A lot of people don't. But it is a protected environment in rehab, but we're giving them that best possible chance by doing all the extra things we do to try and get them into a real world setting and a real world community thing. Okay, I think I'm going to ask you guys something now. Yeah, okay. Last little bit before we do one thing. We also do home visits. So we go out with the OTs and look at the home, look at what's safe, look at what's not. You'd be amazed, I'm sure all of you, how unsafe your homes will be for when you get older. Mine is, it's shocking. My mother's is terrible. She will not pull up her carpets, despite it being a terrible trip hazard for my dad. But she likes them and he has to navigate them, and they've come to an agreement about that. But I actually was building a house when I first got this job, and I said to them about 6 months in, I'm like, oh, because this is what I hope is our forever home. And I said, I wished I'd actually had this job before I built the house, because little things that I've done, like putting lips in bathrooms, now if you've got a stroke or you've had a bad leg or something, or you've got bad knees, getting over that hob, which is only that high, is hard. So you want zero entry. If you're doing any renovations, think of when you're 80. I know none of us are there now, but think about it. So when you renovate things, don't do it from how you feel now. You still do it very stylishly for how you're going to be later. But it's one of those things that is really interesting when you see how a patient lives at home. It's all well and good for us to say, oh, you must do this, you must do that. But then you look at their home and that they might not be able to afford the kind of bed that's safe, or the kind of house that's better. They might have steps, they might have 6 steps. They might not be able to afford to move. So that's an important part of what we do too, is actually having a look at how they're going to manage at home. So we have things like home visits, and we also have community rehab. So people in my role, and also in my health professionals role, that go out to the home and work with patients in the home. So doing what we do in the hospital, but in the home, to really make it gel for them. So it's like, you can do it, it'll be different, but you have to do it this way in your space safely. And using what they have about, they don't have weights at home, they don't have, so what they've got available to them, and using that safely. So that's a big part. And actually for my future learning, that's where I would like to move to, as community. I would love to see what we do in the hospital filter down to actually see people in the community, putting into practice what we tell them. We tell them all this stuff, and usually we know it's worked if they don't come back. If you're ever called a frequent flyer in hospital, that's not a good thing, because it means you're back far too often. And so that's a frequent flyer club none of us want to be in, because quite often we'll have case conference and we're like, oh, it's a frequent flyer. They've been in, 4 times in the last 2 years. No one wants to be there, especially with no one getting actual frequent flyer points at the moment. But so it's one of those things that we don't see. We don't see how they're coping. So I would very much like to do that for my future learning. That's kind of my goal. And as I get older, to get out in the community and do the same job, but at a slower pace. Rehab that I'm in now is quite intense. It's quite, let's go, 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 go. We're sort of patient to patient, therapy to therapy. So yeah, that's what I would like for my future learning. And the last one is assistive devices. So we will fit assistive devices. We will maintain them. We'll explain to the patient what it's for. We will train them to use it safely. And assistive device is a funny term because it literally means anything. So Sharon, your glasses is an assistive device that you can see. I've got a little, where's my phone? I've got a little bump on the back of my phone that makes it easier for me to hold on to. That's an assistive device. Your headphones are an assistive device because it helps you hear. So I always thought it was just a medical thing, but it is really anything that assists you. And I've got a couple of, I didn't know if we could share files from that, and I'm not tech savvy enough. So I've got not a quiz, but I'm going to ask you guys. These are some of the more common things that we use in OT. So I'm going to put up a picture and see if anyone knows what it is and what it's used for. And I'll give some size context because that's what you can't see. So this item is about a metre long, and it's not made out of nylon. And I can't push the buttons if someone pushes. This lady here, I don't know your name, sorry.
Is
Yes.
it to hold and raise yourself from a chair or a bed?
Close. It's not to raise, it's to raise a part of your body.
Yeah, so you just hold on to it and raise yourself.
No, so it's actually, does anyone else know? Close, you're on the right track. I'm actually hoping none of us ever need any of these. But we may. It's actually a leg lifter.
Is it?
So
Sorry, what is it?
A leg lifter. So we have a lot of patients that might have serious edema in their legs. They're very swollen, or they've got a broken hip and their recovery's not been great, or they just have a lot of pain. They have a low pain threshold, and they can't actually, if you imagine getting into bed, they can't get that other leg up. So you would actually put your one side of your, you sit on your bed, get the one leg up that you can, and then the troublesome leg, you hook this into through your foot through here, you hold onto the handle, and you actually lift the leg up onto the bed with you. So that's an example of an assistive device that someone may not use forever. They may use it short term while they're recovering, or it may be that that's what they have to use to get them into the bed. But again, if it's a choice of that or not going home because they can't do it themselves, people are going to want to use that. So the next one I've got is, hang on. This one here. Oh, and this is about, I don't know, 30 centimeters long. So it's quite small. It's a flexible plastic with 2 handles. Any guesses?
Is it to stretch yourself or something?
No, good guess, but no. It's to help you put something on.
Your phone or your
To put your
glasses?
shoes on. To put your shoes on.
Shoehorn.
Clothes for shoes. Socks.
Oh,
It's for
wow.
socks. Yeah. It's called a sock donor. So you basically load your sock and you hook it around these bits here, and then these are just 2 bits of cloth that are handles. So you load the sock. These are very long. They're about 1 meter long, the handles. It's just a bit of ribbon usually. You throw it on the floor. You drag it towards it. You sort of insert your toes in here. And then when you've got right to the end, you pull sharply on these, and it pulls the whole donor out but leaves the sock on your foot. So again, you know, sometimes you might think, I mean, a lot of patients are like, I just won't wear socks. I'm like, well, you'll freeze in winter, won't you? But it's something for patients that maybe they've got flexion issues, hip flexion, they can't get down enough. As I've put on weight as I've got older, I've realised quite how difficult it is to get down sometimes to do things at your feet. So they've either got mobility issues, they might, usually it would be a hip replacement would use that for. So if you have, not the old fashioned, but if you have a hip replacement the standard way, they actually go in surgically through your buttock, through the back part, and they'll put you on hip precautions for about, everyone's different, maybe 2 months, which means that you can't bend. You can't bend over. You can only ever have your body at a right angle sitting. So you can't do that flex forward to get things done on the ground. So we might recommend that for someone so that they could actually get dressed and put their shoes in. You can't use it for shoes, but I didn't have a photo. We normally have a shoehorn, which a lot of us have, but IKEA, and actually in the medical thing here, we use the IKEA one. It's a long-handled shoehorn. It's about 1 meter long. And we give that to patients to see if they can get their shoes on. I actually, I do apologise. I had all this equipment last week. I took it from work, and then I took it back this week, and they've just changed all of our COVID protocols, and for infection control, they wouldn't let me take it out of the hospital. So I had to print off photos today. So sorry, it was an actual thing and it's not now. Okay, this is the next one. This is like, it's hard to see. Okay, actually, I must have drawn a black pen. It's not coming up. Hang on. So this is a black rubber handle about the same size as a knife, and that's a metal loop on the end.
Looks like a vegetable peeler to me.
Yeah, I thought of a carrot peeler.
Not close.
Sorry, Nicole.
This is for people that have one hand to be able to do their buttons up. So it's
I just was
almost like
telling that. Yeah.
did you know?
Said that. I just said, is that something to put on your button, like just to pull your button in?
Yeah, you're right. Yeah. So it's kind of like a threader you have for a needle. You thread the implement through the hole, you pick up the button and you drag it through. So for people that have one hand, my dad flatly refuses to wear a button shirt because he doesn't want mum to do it up for him. So he only ever wears polos or t-shirts. So that problem's been solved for him. But a lot of guys like their button shirt. So we have those implements for those people that have one hand that can't do that. I don't know if this didn't print very well, but I'll try. This one's a bench top. I don't know if you can see it. No? No. Okay, yeah, it didn't print very well. It's essentially a benchtop implement, and what it is, it looks like a little metal cradle with a swinging portion, and it's a kettle holder, a kettle tipper. So if you've got really, really bad arthritis, or you've got no mobility and you're very, very weak in your muscles in your arm, and you need to be able to make that cup of tea or coffee, you actually sit the kettle in it. And then when it's finished, you actually just swing it up. So rather than having to hold, because a kettle with water is very heavy. So rather than holding it and pouring, you just basically, there's a little lever on the side and you tip, and it will automatically tip the water out of the kettle. So when we're doing things like with patients, we do a lot of tea and coffee making. They call the OTs the basket weavers and the bakers of the allied health world. But we will do coffee and tea a lot. And it's amazing how much you can tell from someone by making a coffee and tea with them, whether it's, is their cognition poor? Like, are they putting the coffee in the kettle? Are they overfilling the cup? Is their vision poor? Like, can they actually not see? It's amazing how much difference having a black coffee cup and pouring in water to make a cup of coffee than having a white coffee cup and pouring in the water to make a coffee. If you've got visual impairments, a black coffee cup's a disaster for you. You can't even see the rising. If you've got a white coffee cup, you can see the black color of the coffee rising. So simple things like that make all the difference. And so that's one of the first things that a lot of OTs will do with their patient and get to make a cup of coffee. They can see how they're using their hand or arm, what issues they've got mobility-wise. They can see their safety and awareness, whether they're turning off the kettle, whether they're, potentially going to burn themselves by tipping it incorrectly or tipping it outside of the cup. So it's one of the first assessments that they will do, not assessments, but basically therapy-based assessments to have a look at what's going on for them. They obviously have a handover from the doctor and all those sorts of things, but that's their first practical idea of what's going on for this person. Like, what are the major things? Because making a cup of tea and coffee is quite a basic thing that most of us would do on any given day. And that's one of the earliest things they can use to really direct the therapy and see, okay, how's this person going? What's going to be an issue for them? Okay, this one may not print either. I'm not sure. It's basically a bit of foam tubing. What would this be used for?
Foot
It's
roller.
about the width of a 10 cent. Oh, it's about a 3 centimeter diameter with a little hole through the middle.
It's like a massager, a foot roller, keeping your foot, and then if you have heel pain or something.
Yeah.
No, but a good idea. No, I might try that. Anyone else? No, it's well, this isn't this particular one, but it's called Bradflex, and it's a foam. It's just a little bit of foam, and you could use anything, to be honest. But occupational therapy supplies, we buy this actual thing called Bradflex. We use it to put on things, so spoon handles, knife handles, pens, toothbrushes. So for patients that have very, very weak grip, or maybe they've got poor muscular control, or they've got motor apraxia, so it's kind of a little bit, can't quite control where it's going, it gives them a wider base to work with. So it's quite difficult. If you've ever tried to like cut something or eat, if you've had maybe an injured wrist or hand, or you've got sort of maybe an injured foot, it's quite difficult to do. And particularly when, for some patients, when they're first coming out of their stroke, or if they've sort of not progressed far in their therapy, literally when they squeeze you, it feels like a little butterfly's landed on your hand. It's that soft. So as they progress, one of the main things we do too as part of our therapies is using cutlery, because that's something, again, that everyone wants to do. If we do that, if we use as part of our therapy using cutlery, that means that if they practice it at breakfast, lunch and dinner, they're actually getting occupational therapy 3 times a day without us actually doing it for them. They're doing it for themselves, because if we teach them to use that, so we will give that to patients for the ward, and we'll say once they're at that stage, it takes a little while for some to get there, but we're like, don't let anyone steal it. We write their name on it. And I said, put it on your toothbrush, because then you can actually hold it and control it. There's different widths that we have, so it depends on what we're putting it on. But you can make stuff like that at home. Like I've done stuff for Dad sometimes. I've just basically got your bandage and wrapped around, and then put some, we have something called Coban, which is like a really grippy bandage, which gives a bit of traction. So I'll wrap that around the outside of something so Dad can grip it a bit easier. One of the other things I haven't taken a photo of, but that we use a lot, which everyone I'm sure has in their home, I haven't, is that sticky mat that you put underneath your carpets to stop them from sliding around. We have that all throughout our rehab gym, and it's used for everything. For patients that have one hand, even trying to stir something, the cup's moving around on the bench, so we put it underneath the cup. We put it underneath the tray. When they're cutting something, then the tray won't move. We put it on the tops of jars, so when they've only got one hand, they've got extra grip to try and move it. So we'll have a bit of sticky mat underneath, the jar on top, and a bit of grippy mat in their hand that they can use if they're doing something one-handed, and they can get it off quite easily. My dad has it to get his muesli jar open every morning, because he screws it on quite tight and he can't get it off. So we use that a lot as well. So that's all stuff that, they're all assistive devices, all adaptive things that we use, usually for one-handed, not always, but a lot of the times. The bread flex is for if they're weak, but the other stuff is if they're one-handed. All right, second to last one is this little one here. This is about 50 centimeters square, and it's black rubber.
A form of a seat?
Yeah. It's a
Booster?
Roho cushion. So a Roho cushion, they're all, it's hard to see in the picture. So I wish I had one, but then I couldn't bring it today. They're basically all cells of air. So this is one of the first things our patients will get when they come into hospital if they're not mobile. So if they're in a wheelchair and not able to move, and it prevents pressure areas. I don't know if anyone's ever experienced a pressure area, but they are, they are nasty. And you don't know how nasty until I had a patient ask me to take a photo of a heel one day. She wanted to see how it was looking. Well, I almost passed out when I went down the end of the bed. It was to the bone. So, and that was just from her heel resting, because she wasn't able to move and she'd been at home for a long time. And over time, this had got worse and worse, and she didn't have family, anyone to check, and her skin had broken down to her bone. And once it gets to that stage, it's very difficult to repair them, and that will affect her long term. That affected her therapy, it affected what she could do, and people get them obviously on the, I think it's called your ischius, I can never say that word, the 2 bum bones that stick down. Even if you've got a bit of meat on you like I do, you can get a pressure area from sitting on them constantly. And a lot of our patients, their skin integrity is terrible. They're older, it's dry, they don't moisturize. I mean, I don't moisturize my tootie, I don't know about anyone else, but things that you don't think about can be a major problem. So almost everyone that comes into our ward gets one of these straight away, and they only get it taken away once they're mobilizing. I think it's something like 60 to 70% of the day. They have to be at that level before we will let them go off that cushion, because that can happen, I believe, in like literally a couple of days. You can, all it takes is a little reddened area where you've got pressure that you shouldn't have it. And it's even like an old people's home or aged care. That's why they move patients. Literally, I've seen it happen before. Where I thought, why
Turn them around.
She's so comfortable. Why would you do that to her? Because if they don't, she's going to develop a pressure area, and then it's going to be 100 times more problems that she didn't need. And the last one that I have for an assistive device is this little bad boy. It's basically a white metal stick. Terrible printing. It's about 1.5 feet long. It's got a handle at one end and a little plastic head at the other. I've never mastered this one. When I'm asked to practice it with patients, I'm like, oh, it's my least favorite thing. I find it quite difficult to use. We're going to go deep, dark, and personal with it. It's a bottom wiper. So for patients that don't have enough arm or shoulder flexion to do what we need to do to reach down there to get it clean, it actually has, at the plastic head, it has a little grip underneath. So you wrap the toilet paper around it, you poke it up into the grip to hold it there, then you get down there and you clean it. So, you know, again, not something someone ever pictures that they want to be using, but if it was a choice of that or getting someone to do it for you, I'd rather use that personally. So that's another example of things that we do training with patients. I mean, and that's honestly, we have a bazillion assistive devices. Sorry? Oh, sorry, I thought someone said something. Oh, it's a Lily. Yeah, so that's as bottom wiper.
For some reason, I'm trying to get it off, but I just can't because I don't know what happened.
So basically the last thing I'm not touching on, but there's that, like, it's interesting. Once I start talking about it and thinking about it, I could go on for ages and ages, ever and ever. But it's basically our patient cohort. So we will get anything from, we do a lot of strokes, and it's terrible to say, but true to see that after Christmas, all those periods of, you know, build up of different things, you know, lots of food, lots of alcohol, lots of stress. Our stroke ward is off the Richter. We can be guaranteed there's 6 new patients every day, and then they come across to rehab. A lot of them don't, they're not severe enough, they go home again, but they'll come across to us. We have traumatic brain injuries, we have acquired brain injuries, and they're the ones that have something maybe whilst they're having a surgery, or they might have a tumour on their brain, which is affecting the way they move. We have people that have broken their pelvis, their hips, their backs. We have motor vehicle accident victims, we have burns victims, we have elderly deconditioned patients, we have people that come in for gait retraining. So if you've had a amputation for any reason, we have quite a few people that have amputations for diabetes, diabetic amputations, and they will come and stay with us for gait retraining. So that patient, for example, will see very little speech input, literally none, no speech, maybe a bit of social work. They won't have a dietitian. They'll definitely be doing heavy PT. So 80% of their stay is going to be PT, physio. They'll see us maybe like 10% just to make sure that they can mobilise to the toilet safely, that they're sitting down safely, they're using the rails, they're doing all that kind of thing. We have patients that have amnesia or cognitive impairments after disease or accident. Gilliam, we get a few lately and they seem to come in rashes. It's quite strange. Well, we might not have a certain kind of patient for a long time, and then we have something called Guillain-Barré syndrome, which is a terrible nervous condition that basically your body attacks its own nervous system and it paralyzes you. We had quite a few of those at one stage last year, haven't gotten it at the moment, touch wood, which is a good thing. But we get patients that have conditions like that. Multiple sclerosis, we have patients that have it if they've got an aggressive form that's really affecting their movement. We get a lot of patients like that. Patients with Parkinson's, they come into us also. Literally any condition and any age of patient, apart from pediatrics, we don't do, I think we do from 17 onwards, but any patient, any condition can come into rehab. And as part of occupational therapy, I can literally do anything with them. I could be paying a bill one day, shopping the next, cooking, helping them make their bed, showing them how to get dressed, helping them to wipe their bottom. I did a shower assessment the other day for a lovely fellow who's had a stroke. And then he came into hospital with us. He fell over, broke his affected arm. So he's now got a cast on that. And he was doing really great, doing fabulously. We were doing showers. He's got also speech impediments from the stroke. So again, the aphasia, can't understand what he's saying, but he can receive what I'm saying. He was doing great guns, and then he fell out of bed and broke his hip. Would you believe? The poor man is like the most unluckiest man I've ever met. But, you know, doing shower assessments with him, I've been doing that for 2 weeks. And even though he's a bloke and, you know, it probably wasn't his favourite moment when like we had to get in there and, you know, he's having a shower and I help him when needed, but he's trying to encourage him to do himself. But we've actually built rapport up from it, and it sounds odd and it sounds weird, but when you're in it, I don't know, it isn't so weird. And I never thought I'd be in health work doing that, and I never thought I'd be okay with seeing some of the stuff that I do and doing some of the stuff that I do. I had one patient wanted to tell me about her sex life, and I'm like, woo, I think a little bit too much information there, but for her, because she had a nervous system disease and she had a lot of loss of sensation in her fingers, and she wanted to talk about it, so we did. It was a memorable one, and I probably don't even want to have one of those again, but be amazed at what people come into rehab for and what's important to people, and that was important to her. And for most patients, that's not something that's important to them or they want to talk to me about, but for some patients it is. And again, everyone's got something different, which is their occupation that gives them joy and they want to get back to doing. And that's why occupational therapy is so varied and so wide when you compare it to a lot of other allied health disciplines. And the reason that I really enjoy it, because I really like the variety. But yeah, that's pretty much sort of me done. Has anyone got any questions or any stories of their own, or?
He's so inspired listening to you.
Oh,
I
thank you.
guess people like you should be very strong physically and mentally.
Yeah,
right?
maybe mentally. Physically, I'm actually really not that great. But we have, because in the hospitals here, they're quite strict about we have a no lift policy. So
what are you watching?
we have a no lift policy. So yeah, you do. Yeah, you have to be reasonably strong, not terribly. I mean, I'm 50 and I'm not fit, and I'm on the wrong side of the scales, nudging the fat zone. And so, no, it's something that everyone can do. It helps if you're agile and nimble. Sometimes, particularly because I've got a broken ankle, or I broke my ankle last year, but I still walk like a pirate. And when I get down to pick up something off the floor, I look like some of the patients getting back up again. I keep telling them there to make them look good. So it helps if you're probably a bit more nimble. But yeah, I think mentally, yes. And I didn't even know that I probably was until I started it. I think the key ingredient, the key thing in this job, which is, it's not like caring or like assistant to nursing, but it's kind of, we do some of the same things. It's just flexibility and a lack of judgment. And that's probably the hardest thing, one of the hardest things I found. We do get patients in that have like been in drugs and alcohol, and maybe they smashed their car up because of that, and that's why they are the way that they are today. And then they'll still constantly go downstairs for a cigarette, or they'll go downstairs and we know they come back high. And we're like, wow, we're spending all this time, rebuilding you from what you did to yourself in the first place, and yet you're going back and you're doing it again. But you know what? I don't know that person's story. I don't know. And what I do know, even if I can read their notes, I can read the full patient history, and I always do. So I know when I'm talking if there's any things I should really avoid, or that it would encourage them to talk. But I don't know their journey. I don't know what they're going through. So it's been interesting for me, because I think internally, even if we say we don't judge, I think internally that little kernel of us, we all do a little bit, because we have a certain way that we live and a certain way that we were brought up, or certain values that we hold. And so I do still, in my kernel think, really? But I'm able to not let it be a part of my job. Like, that patient needs what they need from me at that time, and I'm there to provide it. And it's not my job to judge them, and I don't know their story. So you're mentally more so than physically, I think.
Okay. And how do you recruit your therapists? I mean, what is it that you look for apart from qualifications? What do you look for? What are the other qualities?
To be honest with you, actually, I'm about to go on a panel for recruitment for my level of job in the next couple of months, so I will find out more then. I think flexibility is a big one, and I know it sounds stupid, but there must be a technical term. Common sense is another big one. And I think, yes, you need that knowledge, but it's like when we do our course, we do anatomy, and we do, but like, can I remember the correct word for this bone here? No, I cannot, because I didn't do a medical degree that spans 6 years. I do a TAFE course of 9 months. So I think the ability to touch on things and have an idea, but not be concerned if you don't know too deeply. Like, I had a colleague that isn't working with us anymore, and she kind of got obsessed with like knowing. And I said to her, we aren't the doctors, we aren't the OTs, we're the assistants. It's our job to support, it's not our job to lead. And if you can kind of get that mindset, I think you're a better employee for it. I don't know if any of you, maybe age-wise, but I call OT work and even our therapy assistant work MacGyver moments. Does anyone remember MacGyver, that TV guy that used to make a car out of a toothpick and a bit of sellotape? Remember him? I don't know if anyone watched it. It was an American program. It was terrible, but I used to watch it when I was younger. And I think the ability to think outside the box like that makes you very good at this job. So if I see a patient doing something incorrectly, I'll make them a target literally by finding a straw and taping it on the wall next to them. It doesn't have to look pretty, it just has to work. So being a problem solver, I think, is one of the strongest attributes in this job that you need to have. You need to be a solution seeker, not just like, oh, it's not working. It needs to be, okay, it's not working. What are we going to do? How are we going to fix it? I think that's probably one of the most important things.
I think it is being unconditional, non-judgmental attitude. And also the targets. You just keep moving the targets and making it work. That is the flexibility you are talking about. That I think is something we are always...
do those. Yeah, they do the targets. That's right. They check in.
Like working towards getting something. It's just that, like being flexible and making things work. It's not just one way for everyone.
No,
so
that's
it's
100%
attitude
right.
And non-judgmental attitude and readiness to change yourself with each patient. I think it's a great attitude.
Yeah, because everyone does things differently, like how one person, brushes their teeth. And it's quite funny, actually. I do remember when I first started, I had a young OT who was my boss, really nice guy, and I like him. He's an excellent OT, but he'd done a shower assessment on a patient. And he said, I don't know. He said, I think his cognition's on the decline. I think he's got, start of dementia, and I'm going to have to write the note. I'm like, I said, what did he do? And he said, well, he got out of the shower and then he tried to wipe himself with his face cloth, with his little small, I call it a face cloth. Is that what you guys? He said, and it's just, it was his face. And I said, hang on. I said, my dad does that. I said, do you know why he does it? He does it with a damp face cloth in the shower to try and get as much water off his body, because when he was younger, they had to share a towel, and he doesn't want to make the towel too wet for the next person. And this OT was like, really? And I'm like, yeah. I said, so hang on, don't write him off. Ask him how he normally does that. I said, because I have a feeling that's how he normally does it. And it was true. In the end, this guy was cognitively perfect. There was nothing wrong with him. And this OT was new. And I say, he's amazing. He's such a good, I would like him looking after me if I had those sort of problems. But because he was younger and hadn't had that experience and didn't sort of think about, well, how does this guy normally do it? He thought straight away problem. And yet there was no problem. That's how he did it. We all do things differently.
I have a question related to that. When you had a stroke or any kind of a disability, you relearn things, right? According to whatever disability you had or, the shortcomings you had. Generally in India and all that, we haven't heard of occupational therapy very recently only. We started hearing about it and all that. My dad had a stroke when he was in his 50s, and there was no physical disability as such, because he could walk, he could talk and everything, but there was a lot of emotional component, and he couldn't do, like you say, the little things he do on a daily basis kind of thing. He was a bank cashier, so he had to go to the bank and count money and all that, which was a easy thing for him to do. But after the stroke, it was he will not be able to do that. He kept forgetting, instead of counting lakhs, he can't even count 1,000 rupees, and there will be mistakes. But that was not part of the rehabilitation process at all. They looked at him, he's okay, and they let him go. So the kind of things we did at home, we actually kind of pushed him to do things because he was he was saying, I can't go back to the bank and all that. So I used to sit with him and make him count money or whatever. And when he started going for work, we actually informed the bank that he's, whatever money counts, please count it again for some time, because he might make mistakes and all. And the bank was very like, cooperative. But what I'm asking is like, even I am somebody who's prone to injury. I keep injuring myself. And I kind of learned, because I don't have like access to, or most of the people in India don't have access to things like this. So we kind of come up with our own system. Like one of our relatives, she had a stroke. She couldn't walk without help, and there was no help. So what she herself asked for it, like to put holders everywhere. So the whole house had like holders everywhere, so that she will walk from one holder to the other, and rails in the bathroom and everything. So it is like little inventions of their own, not like somebody comes and help them with things or anything. So my question is there a wrong way to relearn things? Like, because we come up with our own things, is it going wrong than like going to occupational therapist?
I don't think if you're doing something about it, like you're obviously doing pretty much my job for your dad without being paid for it. Like that's what I do. I encourage patients to do things themselves, and you were basically doing that with him. And I don't think there's no wrong way as long as you're trying, but particularly in Australia, you've got to remember we're very highly regulated here. Like there's a rule and a law for absolutely everything. So in that sense, I would say that they say, yes, they're like, for example, all the rails that your friend has in her house, when like a patient's never allowed to do that themselves, we have to tell them where it's going to go, because it has to go in certain safety points, it has to go at a certain height, it has to go, there's all these rules. And I know it's different. You're in India, aren't you?
Yeah. Right now I'm in Bahrain, but I'm from India.
Okay. Yeah. So yeah, and Bahrain's a bit the same. I mean, it's just not as regulated. So yeah, to me, if you're always trying, you're doing better than nothing. It's better than doing nothing. Even if you're not doing it 100% correct, if you're doing something, it's better than nothing. It's like with your dad, as I said, you were helping him to do that just by living your daily life and encouraging him to do those things. And it's a shame, for him that he didn't have that rehabilitation. And I can only imagine, actually, honestly, you've literally described one of my patients at the moment. He works in a cashier shop, and he can't count money now. And he's walking, talking, everything's great. He can't count money, and he literally cries every session because he gets so frustrated, because he's like, he can't like add up 10 cents and 5 cents. He just can't do it. And everything else is fine, but that doesn't work for him. And it must have been so frustrating for your dad to have that. But I think
he went back to work, and he finished his career. Yeah, he finished he got retired afterwards and all that. So
wow, that's amazing. Yeah. I mean, honestly, as I said, you basically did my job, your job.
No, everybody at home and kind of keep making him do stuff. So it was like it was a group work.
And he's lucky. He's lucky that he has, and that's an important thing too. Like my mum with my dad, she doesn't do a lot for him. She does what she needs to, and she said, I know people think that I'm horrible, and they maybe do, but it's actually her not fawning over him and only doing what he really needs to for him has helped him stay on his feet as long as he has. He potentially would have declined quicker if mum had been, I'll cut that for you, I'll do that for you, I'll get that off for you. She never has. She's always like, she lets him do as much, unless it's not safe, but she lets him do as much as he can, which keeps him doing his little thing. So there is definitely a safer right away, like bars and that, to do things than, it'd be a shame if like she put one on a part of the wall and it gave way. So there is in that way a regulation and a proper way to do things. But as long as you're doing something, I think it's better than nothing. It's better she has a rail there that might not be the best, and she has nothing and she falls and she can't get to the toilet. So, it's a tricky one. And I think, occupational therapy is not that old. I don't know. I think it's 1950s, I want to say. I did this for a speech a while back and I've forgotten. But I hope that it becomes more prevalent everywhere, because it really is. It's just the overall person. So physio, like you say, the hospital doctors, he's walking, he's talking, he's great. It looks at one part. Occupational really does look at everything. We say we deal from the waist up and the hands, but just because when patients get confused, when you see them in hospital and they're like, I've got a physiotherapist, it's like, no, we're the occupational therapy. So we kind of say it's top, we look at the top half, they look at the bottom half. We try and put patients that get confused, that's how we put it to them. But occupational looks at the whole person, the whole thing, The physio really just wants to get them. I'm not putting down physios. The ones in rehab are phenomenal. They look at the whole person. That's their job too. But they just want to get them stronger and walking.
And I have seen them doing wonderful work with the people with mental illness also. I used to work in a psychiatric facility. So that is when I actually first learned about occupational therapy and all working with them. So they made really wonderful changes in some of the residents and all that. So
it's a very close, we have quite a few patients that have mental health issues, and I can see, because I don't know much about mental health, I haven't worked directly in it, only from the patients that come through, but I can see the very tight correlation between mental health and OT because of that engagement, that occupational engagement, because a lot of mental health is, well, I don't really understand mental health, but it's obviously you're not doing things that you enjoy, or the things you are doing aren't giving you pleasure. So it's kind of finding that space to make sure that they are engaging meaningfully for them. What's meaningful for me might not be meaningful for you, or do you know what I mean? So it's really about digging deep, and that's why we have in our rehab team, we have a clinical neuropsychologist, and all of our patients see her, because that's kind of, she digs out little kernels, she gets in there and ferrets around in their minds and really digs deep into, and for a lot of mostly our cognitive patients, she's super important. So I will do joint sessions with her, with the patient, if it's a cognitive one, and I sort of, I take her lead as to things to say, things not to say, triggers, stuff like that. But yeah, I think mental health and occupational therapy is very tight.
Nicole, if I may ask you, what would your definition be of recovery?
Is that the one? I know. I'll be honest with you. Is that the one you sent me? Recovery to Uncover or something?
Did I send it to you? I, in fact, wanted to ask you about recovery and uncovery. How strange, but I didn't send it to you.
It said recover to uncover. I don't know. I put my own slant on that. I did a bit of digging when you sent that to me, and I couldn't find anything. But I would say
I couldn't remember sending it to you, but these are the two words that were working in my mind: uncover and recover. What do you uncover in recovery?
I think it was recover-uncover. So I took it to be like you recover from whatever, whether it's an injury, whether it's an illness, whether it's whatever, and you uncover new ways to do things. You uncover maybe things that you didn't know you could do. You uncover things that you may not have known you enjoyed, or you uncover a new way to enjoy it. So, maybe if you enjoyed playing the piano and you can't anymore, maybe you join online piano playing tutorial, you know what I mean? Like, it's kind of about, it's just finding a new, so I took that to be, recover from whatever's changed your life, and then uncover a new way to enjoy that same activity.
And it is quite interesting that you thought of it. This is something that I always toyed with, these two words. So to me, recovery is getting back to the state that was before, the earlier state. Recover to that state. Whereas when you uncover, after trauma, you are uncovering whatever potential you have. So that is how I have reasoned out. I have reasoned out. I really don't know, because I was also fascinated by these two words. Recovery and uncover.
Great minds think alike, clearly.
So I don't know how acceptable it is, but that is how I thought. Uncover and recover.
Perfect example again in the way that everything has a different meaning to everyone. So even those two words, have a different meaning to different people. It's all in a similar vein, and it's all in a similar approach, but it has a slightly different meaning, and that's exactly what occupational therapy is about, finding that meaning in something for you. So for me, certain things may not hold meaning, but for a patient, it might be so important to them. And I have at times, it's even like this fellow with his beer. It's a tricky one for me, because I'm pretty sure that's how we ended up with this in the first place. I think he fell over and broke something because of the beer, and and this is, we put it on the cup, and that's what he's reaching for. And I'm like, it's kind of like uncovering what works for him, and I'm kind of, it doesn't work for me, but it works for him, and it's not about me, it's about him. And that's something that we quite often say to patients. They're like, patients are like, oh, thank you so much for everything. So I said, and we always say to them, it's like, we didn't do anything, you did the work. Like, you You did the work. Don't thank us for doing the work. You did it. You know, we just help you. We're just there to give you a bit of feedback, give you a bit of guidance. But really, when it comes down to it, you are the person that's doing the work.
I totally agree on it. I think it's the person's acceptance and the positivity to get better puts
Yeah.
a lot, I mean, eases up with you people. Like, you know, a person who goes through that should have that mindset, the frame that, yes, I have to get out of it. I'm finding ways to do it. I have to somehow get back to a little bit of normalcy. So probably
Yeah.
that helps a lot.
Yeah, it's finding
And,
that. I always
So,
say, find your new normal. You're going to get a new normal. You've got to
right.
find it.
So Nicole, my question to you is that, like some of us are here in that stage of life where we are past our 60s and heading towards, old age, sort of. We are not
Yeah.
like in any ways handicapped or anything, but we might be approaching a stage where we might find that certain things are not going to be easy for us, or we may need some sort of a help. How can we prepare ourselves mentally? I mean, what have you seen from your experience? What would help us mentally prepare for that eventuality, to be stronger or whatever? Or is there a way that we can start thinking of that and prepare ourselves mentally? That's my question.
Yeah. I mean, already with the book group, I think making sure that you have something that you enjoy, and it's always great. I mean, it's wonderful. If you enjoy climbing mountains, fabulous, and go for it. But that is difficult to do as you get older. So to try and keep a hobby or enjoyment that you can see yourself doing when you're older, so that if you're not as strong or you're not as that, so you've got that interest. Like we have quite a few patients that come through, and it's much harder for them. They're super active. They never sit down. They never don't read, don't watch television, don't like music, and it's like, whoa, it's quite difficult for us to engage those patients because there is, and these are the ones that are literally, they're in a wheelchair and they've got very poor movement of their limbs, and it's like, and they can see they decline mentally because they're never going to be able to get back to doing what they wanted to do. So I think it's about maintaining some interest that you can see yourself doing as you get older. And the reality is, and it's hard, it's easy for us to say sitting, in our not wheelchairs, and, the reality is, I just think it comes to all of us. And I think we probably need, for me, because I had the surgery last year and like I had to strip down out of my clothes and had to sit on a commode in the toilet because I didn't have anything else in hospital. And I was like, oh my God. I think it's just a realization that literally care workers have seen it all before. They don't care. And if you get good ones, they're there to help you. And I just think we're all going to need help. We're all going to need different kinds of help along the way. And you can't, by taking that help, you actually make life easier for those around you. And I get that question a lot from patients, usually, married couples, and the husband or wife has had a stroke. And they're talking about sending them to nursing homes. And the partner's like, no, I want them home. I can look after them. And it's a bit of tough love, and sometimes it's just not physically possible, but we actually make people come into the hospital. We do what's called an independent living unit trial, and we make them do it for like 2 or 3 days. And it's amazing, how much those people learn in those 2 or 3 days. It's just not possible. And then with that person going into care, I always say to them, you've got to remember, if you accept this help from care or whatever it might be, it means that your partner can actually enjoy their time with you, not have to do everything for you all the time. So it's kind of, I think that realization, the more help that you accept, the more enjoyment your people around you will get from you, because they won't be doing for you all the time. They don't have to worry about you all the time. They can just see you and enjoy you, knowing that someone else is taking care of the stuff that needs to be done. It's a hard one, being married to someone for that long, you don't envisage not growing old together or, and having to have that help. But it means that by letting people help you, you can actually let the love people around you enjoy you more. I don't know.
Makes sense. Thank you.
I don't have any, I must say, I don't have any words of wisdom on that one. I'm kind of like, yeah, it comes to all of us, and short of just keeping ourselves healthy, but you know what? At a certain point, keeping ourselves healthy. But I've got elderly patients that still smoke. And, you know, probably they'll die the day they probably stop. And they look at me and they say, oh, I said, you know what? I'm not judging you. I said, you do what works for you. I said, if that makes you happy, I said, you do you. I said, I'm not here to tell you not to. You know what I mean?
Thank you, Nicole.
I had my glass of wine. It's only one.
Nicole,
Very
sorry, can I
good.
have a last question there, please, if you
Yeah.
don't mind? Hi, sorry, I was trying to get in and out. Zoom was kicking me out for quite a while, so it took me a while to get in. But coming from the mental health side of things, I'd like to ask you, because you're there very hands-on, what do you see that is really something that makes a difference for your patient? Because say I would be on the other side, kind of I'm coming from the clinical psychology point of view, so I'm kind of looking at the patient's mental health, but then on the physical side, when you were there, you were the hands-on person. So what do you see that could really bring them the most help when they are in that situation? Because I just like to understand, is it family support? Is it structure around them? Is it the physical things that they get? What is it? Or is it a whole sort of things? Or could you point one thing that is really, really important?
I mean, to be honest, it's probably the fact that they have a team that looks out for them. So and we always remind them of that, like there's a whole team that looks out for them. But probably from my personal perspective, it's just treating them like a person, because a lot of people don't have family. It's hard to know, because some do have family. Obviously, the ones that have family supports probably have a better prognosis than those that don't, because they've got that framework to rely on. We've actually got a patient at the moment with mental health issues who discharged, and unfortunately he bounced back a day later because he wasn't coping, and he had burns that he had to dress himself, and he can do it, but he thinks that he can't. And so because he doesn't have any of that social support or that family support, it's very difficult for him. So I think definitely family and friends. We have a lot of people that have, they belong to a ladies choir group or something like that, and they're in their 80s, but they also have friends visit. They might be on their own. A lot of our patients have already lost their spouses, if they're elderly by the time they come to us. But on a day-to-day level, from my point of view, I try and greet every patient by name. As I walk past their room, I try and give them a wave, like we're in the streets having a wave, like we're not in hospital. I try and make sure they've always got clothes and they get dressed in their clothes, because that's part of rehab. We like to have them in their clothes and not in their gowns, but I'll encourage them, like, come on, get out of the gown, get your clothes on. And it's just trying to make them feel like they're in that real world as a person, that they're not just a patient, they're not just a number on we do have a schedule for them, and it's intense, but just literally trying to remember, how's your grandkids today? Or, how was your sleep last night? Was it all just little random, like you'd ask your friend if you saw her, like, oh, how are you today? And just things like that to try and make them feel that they're not just a patient, they're a person.
Natural as possible. Yeah, as natural as possible.
Yes, we've got 30 patients and I forget, and I'm like, God, I'm awful with your name. I said, but I remember we talked about your little son and he's got a dog yesterday. How's the dog going? And they're like, oh, great. I don't care that I forgot their name. As long as I can remember one random thing that we talked about, then it just engages another conversation. And the ones that are with us longer, I'm actually better at obviously remembering their names. But just trying to make their day, and just if we pass them in the hallway, like, oh, how you doing? Just keeping it, even when we're having breakfast, and I'll be honest, in a rehab unit, breakfast and lunch and dinner can be quite confronting, because there's 30 people there with all varying kinds of conditions, and some of the food's flying in every direction like you wouldn't know it, and then there's cognitive patients, and then there's patients that can't swallow, but I'll literally walk in like, how's breakfast going? And you just sort of not pretend that it's not there, but you acknowledge it, but don't dwell on it, I think. And that's important, like acknowledging. And with our mental health patients, because I don't have that kind of training, I don't have any, psychological training, but I use my thing, like, I wish I had the answers for you, but I don't. I said, but today we're going to work on this, and I can help you with that. So we're going to do that, and chunking it off into little things, like we're going to do this today, because I don't have that mental health.
Because I really think like these, even breaking down like that, what you're saying is it makes difference for them, because it's like little victories. If they can see the little victories, it's just, it's a progress. And that they overall, the big picture could be, something overwhelming and too big, isn't it?
Yeah.
And just breaking down like that, it's a good thing. Yeah.
Just little chunky things.
Thank you.
And we quite often, when we do therapies, we can see when we've ramped, as an assistant, we don't grade. We can, with experience now, I can a little bit grade up. We can always grade down, but we can never grade up. But as I said, now that I've been at it a few years, I am allowed to do that. But I can see if something's failing, if it's not working, we'll persevere to a certain point, but then I'll pull it back, we'll stop, and we'll do something that I know they can do. Because again, it's that victory that, like, I don't want to end a session thinking like, oh, I couldn't do that. I want them to end like, oh, right, okay. So yeah, we kind of always structure our therapies that way as well. Like even for that patients that don't have mental health issues, just for any patient, we want to make sure that they're seeing that little progress. And look, and they'll have days. If we had a fellow yesterday, day before yesterday, and I said to him, he just wasn't doing it. He was so tired. And I said, mate, today's just a crap day for you. I said, and that's okay. You're going to have them. I said, I had a crap day yesterday. I said, it wasn't as good as my job as it could have been. I said, so you're going to go back to bed. I said, and we're going to see you tomorrow, and we're going to start all over again. And you just need to do that. Like, it's just real, isn't it? We all have crap days.
Yeah.
And if I'm seeing patients at their crappest day I'm seeing it, but they're their lowest. They're not going to get any lower. So, well, hopefully they don't want to go any lower, because then that's not good at all. We don't want to go, but we're seeing them. And that's why I always say to people, and sometimes nurses, not always, but they're very busy nurses. And sometimes I think they do get short because they've got so much to do. It's different for us. We come in and out for an hour, they're with that patient all day. But I'm like, you got to remember, you're seeing this person, maybe the patient swears at the nurse or is not nice or whatever, and it's not acceptable. They don't have to put up with it, and the patient shouldn't do it. But I say to them, you're seeing that patient at their lowest point, like their lowest point. Think of you on your worst day, multiply it by 100. That's how that person's feeling. I said, so just, either walk away, get someone else, but don't retaliate. Don't, it's not personal. And I think it's really important to remember that we're seeing people at their lowest ebb, and it's our job to try and build it, not decrease from it.
Mm-hmm. Absolutely.
Did empathy come in from your job, Nicole, or was it something that you gathered as you went on?
Sorry, the first part?
Was empathy something inherent in you, or something that you gathered as you went on?
No, I think so. Yeah, I've always, at work now, I always think, oh, what if it was my mum? What if it was me? I sort of think about that. So that's why I think I've always been a bit like that. I've always been, I'm never really good at arguing, because I can kind of see both sides of the arguments. I'm really a bit pointless at arguments, and I'm a bit lazy to have them, to take a lot of energy to argue. So I'd rather divert it into other things. But yeah, no, I've always been quite like that. I think, it's one of the key things that you do need to have in this role is, and I do always put myself in that patient's shoes and think, well, what I want, even such small things as they'll put patients in a wheelchair and they leave their t-shirt rucked up above their muffin tops. So I pull their t-shirts over their muffin tops, because I don't want my muffin top hanging out. So I want someone to do that for me. So yeah, I think I've always been quite like that. I don't think you can grow that skill. I don't know, maybe you can, I'm not sure.
So AI will not take on OT. It's got to be a human interface, isn't it?
We do. We're starting to use a lot of IT-based interventions. So we have things like for cognitive stuff, and we use iPads for certain things. But yeah, I don't think. I don't know. Who knows what the future holds? But no, I think it's kind of like OT's like, if you think about, because I equate it back to water slides, because we used to work in a water, that's what we took us overseas. And a water slide is an interactive ride. So as you go down a water slide, every single person rides differently. You could have your hands out, you could be shouting, every person rides that ride differently. Whereas if you're strapped into a roller coaster, there's not much you can actually do. It's not an interactive ride. You're strapped in. Yeah, you might wave your arms and that, but your body's in the same position. You're strapped in. You're going to go where it goes. You're going to stop when it stops. Whereas the water slides, you might slide up that way. You might slide that way. You might go to the end of the pool. And I think OTs like that. It's an interactive ride. Every single person's different. Every activity's different. It's just too different. So I don't think AI would ever, I don't know, I shouldn't say ever, be able to effectively grasp that, and the emotional side of it. I don't think that'd be, AI wouldn't be, I hope they're not competent on, otherwise we'll all be out of jobs.
To enlighten the Bahraini residents who are here on the group, Nicole's husband came into Bahrain to set up the Lost Paradise of Dilmun, the LPD water park.
That was the voyage, sorry, that was the water slide reference.
Built it, yeah.
So yeah, for me, a vast turnaround from those days to these days, but interesting nonetheless. And you know what? I actually always say, and I said that in my piece that I did last year, which is on Facebook, which is what sort of kicked this off, Sharon, but I was working at Palazzo Versace, which is a 5-star hotel. I think there's one in Dubai. Is there one? Still one in Dubai?
There is one in Dubai.
Yeah. So that's where I was working here. And when I went to health, people were like, what the, like, complete turnaround for you. I'm like, tell you what, it actually isn't. It's essentially customer service, just in a different arena, just in a different area. I'm polite to my customers. For the first 2 years, I kept calling all of my patients clients, and then I get it all confused. And then I'd call them guests, and then we have an Airbnb. And so then I call my guests patients. I get very confused. But it's basically, it's 5-star service, just in a different arena. It's being polite, keeping people informed, doing what you can do, knowing when to not do what, to get help when you need help. It's really just service in a different arena.
Shireen, shall we wind up?
Yes, thank you for the lovely
Thanks,
narrating, so much of information that you gave so willingly, Nicole. Thank you very much.
Thank you so much,
Sorry
Nicole.
about last
Thank
week.
you.
I'm glad you guys managed it today.
Thank you.
It's absolutely fabulous. Thank you so much.
Yeah.
Thank you,
Yeah.
Nicole.
Thank you so much for the wonderful insights, Nicole. I
Yeah.
mean, it
Now everybody
shows
has
us
to
a way
make their
forward.
houses like friendly, old friendly or something. That's the good. Actually,
If
that is a
anyone's
good
got any
point.
random questions or anything, even about anything, you'll just email me. Shireen's got my details. I'm sure you probably don't, and it's just a nice, it's an interesting way to touch on a topic and then think back like, oh yeah, so oh no, I forgot to ask you, what were the 5 words we had to remember?
Oh Lord.
Ah.
I remember red,
Peace,
velvet,
velvet, red church,
Daisy and red.
Daisy.
But did anyone remember them all?
Yes,
Yeah.
yes, I think so.
There you go. Well, you're not ready for the nursing home yet. So when they do that test, whenever they're having a bad day at work and they look at me and I'm like, face red, I try and remember all the words. And when I've tried to do that test with an X, like I've had old nurses that have come through and they know doing a cognition assessment and they get super cagey. But we do that, and then after the end of it, so at the end of like an hour, we ask them those words. I mean, if you can imagine, if you're older, and how hard, and that's just one part of it. You also have to know how to count backwards from 100 in sevens, take 7 off every time. Oh my God, like it's complex. So none of you are ready for the funny farm yet. You're all good.
What were the 5 words, Nicole?
You got, see, I've forgotten them. Face, velvet, church, daisy, red. They change them, I think, like every 10 years or something. I'm not sure because it's an actual.
I'm still okay. I'm still okay for now. Thank you, Nicole.
Thank you, Nicole.
Thank you.
That's a wonderful session.
Thank you so much.
Bye.
Thank you.
See you all next month. Bye.
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 Bye. Enjoy your party.
I will. Thank you.
Okay. Bye.